Good morning, respected teachers and my delegates. Today I am going to present a case report on unilateral optic disc melanocytoma. So I have no conflict of interest and no financial support and sponsorship. So beginning with the introduction, as mentioned, the term melanocytoma was first coined by Zimmerman in 1962, who described it as a benign asymptomatic hematomatous tumor arising from melanocytes. It's a rare ocular pigmented cell tumor which commonly involves the optic disc, and its commonest presentation is in the 5th decade of life with a female preponderance. And most of these melanocytomas do not usually cause a significant visual impairment. 93% of cases had presenting vision of 25/40 or even better, and visual field loss has been reported in few cases. Malignant transformation has been found in 1 to 2% of cases, hence necessitating long-term follow-up. So my case report, it's about a 44-year-old female who came with a complaint of gradual painless diminution of near vision in both eyes for 2 years. The best corrected visual acuity of right eye was 6/12 and near vision in right eye after correction was N8. Best corrected visual acuity of left eye was 6/6 and for near vision it was N6 after correction. Anterior segment evaluation of right eye was within normal limit. The pupil in right eye was round, regular and reacting to light. No RAPD was observed in right eye. Intraocular pressure in right eye was 12 millimeters of mercury measured by Goldman's applanation tonometry. The fundoscopy of the right eye revealed an elevated, well-defined, hyperpigmented brownish lesion with feathery margins in the optic disc region. A fundus autofluorescence was done, which revealed hypoautofluorescence corresponding to the pigmented mass on the optic disc, and a fundus fluorescent angiography revealed a hypofluorescent mass in all the phases. So this is my fundus photograph. As you can see in the right eye, there's a well-defined hyperpigmented brownish lesion with feathery margins in the optic disc region. The left eye's fundoscopy is well within the normal limit. We did a spectral domain OCT which showed distortion of the optic nerve head anatomy with presence of a dome-shaped elevated mass lesion. The outer thin layer of that mass lesion was hyperreflective, which may be due to the melanin deposit, with abrupt and complete shadowing behind, obscuring all the details of the optic nerve head. A B scan of the right eye showed a hyperechoic small dome-shaped lesion, which was 1.8 millimeter in thickness with 2.0 millimeters into 1.6 millimeters base over the disc. And Humphrey's visual field perimetry 30-2 showed mild enlargement of a blind spot. All the above mentioned investigation modalities helped us in the diagnosis, as these features were consistent with melanocytoma of the optic nerve head after excluding various differentials to reach the final diagnosis. A follow-up period for 1 year was uneventful. So this is my OCT picture. You can see that the anatomy of the optic nerve is distorted, and the outer layer, as I mentioned, is very hyperreflective with abrupt and complete shadowing behind. Now these are my possible differentials that I had kept after my diagnosis, before reaching my diagnosis. So one was a choroidal melanoma, which is very clinically very difficult to differentiate, but if we use B scan and fundus fluorescent angiography or an enhanced depth imaging OCT, we can get the characteristic features like B scan has a dome-shaped mass with acoustic hollow zone within the tumor. FFA and ICJ will show a double circulation pattern, and in enhanced depth imaging OCT, there will be optical shadowing and thinning of overlying capillaries and subretinal fluid. Choroidal nevus was unlikely because it's a flat and minimally elevated and lies usually outside the optic disc. Retinal pigment epithelium hyperplasia, there's no history of ocular trauma or inflammation, and usually these have irregular margins associated with chorioretinal scarring. Combined hematoma of retina and the retinal pigment epithelium usually have a juxtapapillary location, and they're usually associated with retinal gliosis, which can lead to traction, and there will be stretching or corkscrew vascular changes. The adenoma of retinal pigment epithelium, usually they appear yellow to orange in color, and they usually have no feathery margins. And a metastatic melanoma to the disc, they usually grow very rapidly, diffusely infiltrate the disc, and the disc may appear as that one in papilledema or papillitis, and a distinct black mass is usually not seen. So none of these features were persistent with whatever we had. So we reached a final diagnosis of optic disc melanocytoma. Coming to the discussion, as I mentioned, it's a hematoma consisting of large, uniform, round or oval, heavily pigmented melanocytes. In a study conducted by Lee et al., 93% of the cases had a presenting vision of 20/40 or better, and RAPD was only present in those with 20/50 or worse. Possible complications, very important, include local compression of the optic nerve, exudative retinal exudation, juxtapapillary choroidal neovascularization, tumor necrosis, CRVO, or malignant transformation in 1 to 2% of the cases. Visual field abnormalities include enlargement of the blind spot or nerve fiber bundle defects. As mentioned, very few documented cases of optic disc melanocytoma have been reported in the world literature, and still few cases from India. So assessing the characteristics of this rare tumor with reasonable degree of certainty from clinical entities like malignant melanoma, which have aggressive nature and poor prognosis, so as to avoid erroneous enucleation and prevent systemic metastasis of utmost importance. So these are my references. Thank you.
This is just a case report you wanted to show.
Yes, sir.
What is nobility in your case?
Sir?
What is nobility in your case?
Sorry, I couldn't hear.
What is new in your case?
Sir, as such, nothing is novel because this is a very benign tumor, but the only message that I want to give is that these kind of patients require follow-up because even though there are few chances of malignant transformation, but since a very close possible differential is choroidal melanoma, these kind of patients need supervision and they need to be under regular follow-up.
You said there are very less likely chances of turning it into a malignant tumor.
Yes, sir.
But if it turns, what are the changes which you will be looking for?
Sir, there will be a rapid growth, rapid increase in size of the tumor, and it will be associated with severe loss of visual acuity if there is invasion.